Good morning, everyone. My name is Alazy Victor from the New England QIN-QIO, and I will be your moderator for today's webinar. Session 6, Measure Your Success, Monitoring and Tracking Data. Before we get started, just a few housekeeping items. This call will be recorded for training purposes. The phone lines will be on mute for the duration of the presentation. The phone lines will we will take questions at the end of the presentation, and I will provide you with instructions on how you can ask a question. At this time, I'd like to introduce Carrie Barton with the Massachusetts Department of Public Health.
Good morning, everyone. It's my pleasure to introduce Dr. Shira Doron and Dr. Beaulac today. Shira Doron is a physician in the Division of Infectious Diseases at Tufts Medical Center. She has been the physician head of the Antimicrobial Stewardship program there since 2005 and is also the associate hospital epidemiologist. On a national level, Dr. Doron serves on the Society for Healthcare Epidemiology of America Antimicrobial Stewardship Subcommittee and the Infectious Disease Society of America Antibiotic Stewardship and ID Leadership Working Group. Here in Massachusetts, Dr. Doron has been involved in several statewide initiatives to improve the care of patients with suspected or confirmed infection. Dr. Doron has numerous publications related to antimicrobial resistance and stewardship. Kirthana Beaulac is a pharmacist who trained at Massachusetts College of Pharmacy, completing postdoctoral training in infectious diseases at Hartford Hospital. She is the pharmacist head of the Antimicrobial Stewardship Program at Tufts Medical Center, as well as the infectious disease pharmacist for the institution. Dr. Beaulac is involved in the Massachusetts Society of Health System Pharmacists, the Council of Boston Teaching Hospitals for Pharmacist Education, and the Society of Infectious Disease Pharmacists. Her research focus is in methods of optimizing antimicrobial use. Thank you, Shira and Kira.
Thanks, Carrie. So today we're going to be presenting the sixth and last webinar in the series, and this one is called Measure Your Success, Monitoring and Tracking Data. And the objectives today are to describe the critical elements of an antibiogram, to identify strategies for compiling a useful and accurate antibiogram, and to compare various methods for tracking and reporting antibiotic use. So first we'll start with what is an antibiogram. It's an overall profile of antimicrobial susceptibility testing results of a specific microorganism to a battery of antimicrobial drugs. It uses aggregate data from a collection of microbiological reports. And this is what an antibiogram looks like. This is the 2015 Tufts Medical Center antibiogram, just the gram-negative part. And this is the way we put ours together, and there are ways to customize the antibiogram for your own use. But in general, an antibiogram has the various organisms isolated from that institution along the left-hand column. And then along the top, you have the various antibiotics that are active within that class of organisms. So for gram-negative organisms, you can see all of these antibiotics, but you won't see something like nitromycin, which is only on the gram-positive part of the antibiogram. Here you can see that the number of isolates in that year for each organism are in parentheses. And then in every cell, you can see the percent susceptibility of that organism to that antibiotic. And in some cases, certain antibiotics are not appropriate for testing against that organism, or there is no data, or certain bug-drug combinations carry intrinsic resistance, so they would not be tested or reported. At Tufts Medical Center, we also break out certain organisms from certain sites that we feel are particularly useful. For example, E. coli coming from urines in the emergency department, and E. coli coming from urines in our general medical clinic. That way the providers in those areas can really have a very specific guide to help their empiric therapy of UTIs. And then down below, we specifically break out the number of organisms in various categories like ESBL and carbapenem resistance. Where does the data come from for the antibiogram? It comes from each particular antimicrobial susceptibility report that is done for every positive culture. So Mr. X provides a urine specimen. That urine culture grows E. coli. That susceptibility pattern looked like this. And then all of those cultures aggregated together form the antibiogram data. So how do I make an antibiogram? There are a few different approaches. One is to ask your reference microbiology laboratory whether they can provide one, and in some cases they can. Another is to use a third-party data mining tool, so to actually purchase a tool that will take the data and create an antibiogram for you. And the third way is by hand, manual tabulation. I'll show you a little bit about how that works. We recommend Microsoft Excel and creating a sheet specifically for each organism. So in this particular example, there's a sheet for E. coli, and a sheet for Pseudomonas, and a sheet for Acinetobacter, etc. And each column on that sheet represents an antibiotic, as you saw in our example. It's easier to follow the order that they use on your microbiology reports from the lab. And then each row should represent a single patient isolate, excluding duplicates. So you want to exclude 2 or more isolates that are from the same patient, of the same organism, from the same site. We'll talk about that a little bit more. So here are some examples of how the Excel spreadsheets would look like when you're working on the, here's an example of an E. coli section of your manual tabulation to create your antibiogram. And in this other portion here, this is an example of a situation where your facility only uses one microbiology lab. And so for that microbiology lab, E. coli always is subjected to the same susceptibility panel. So these are the antibiotics that are used to test susceptibility against E. coli in every single report. And so 1 might be susceptible and 0 might be resistant, and you can tabulate your results that way. In this example below, your facility would use more than one laboratory, has a variety of laboratories depending on the day or the week or the month. And you can see that the lab is indicated here in this column. And so each laboratory actually, even though the organism is E. coli, might use a different panel, a different group of antibiotics to test against E. coli. And so you can see that for some antibiotics are tested and others are simply blank, and other laboratories might use different ones. And so in that case, you actually have to be calculating the denominator for each antibiotic, how many times was the organism tested against that antibiotic in order to figure out your percent susceptibility. So it's a little bit more work there. Now, there's some major caveats when you're creating your antibiogram. And we like to say garbage in is garbage out. If your data going in aren't good, then your output won't be as useful. And some of the warnings are duplicates, which I mentioned. Now, if you take out duplicates, which is same patient, same organism, same site, which you should, it's important to remember that whether you use the first isolate from that patient, that site, or the last isolate, there are going to be problems either way. If you use the first isolate, keeping in mind that if a patient grows the same organism over and over again from the same site, it might actually be because that organism is developing resistance to the antibiotic that the patient is on. And so that first isolate is really going to underestimate the degree of resistance in your facility. On the other hand, if you use the last isolate, which some antibiograms do, you're going to be overestimating resistance in your facility. So you simply have to keep that in mind when you interpret the results of your antibiogram. Small numbers are going to really skew your results in one direction or another, and usually we use a number of about 30 to be considered a reliable number of isolates to be able to tell what your resistance trends are. And if all of your numbers are small throughout your antibiogram, you may want to consider a time frame that's actually longer than 1 year, keeping in mind then that it's not going to be as accurate a representation of changes over time. Antibiograms generally are not adjusted for census. So if you are seeing more and more Acinetobacter, for example, it may not be reflective of the growing Acinetobacter problem in your facility. It may simply represent that you have more residents in your facility than in prior years. General antibiograms do not to distinguish colonization versus infection. So in the Tufts Medical Center antibiogram, we do not include results from cultures that are clearly screening cultures. So MRSA nasal swabs and VRE rectal swabs don't go into our antibiogram. But certainly we know, and we've talked about over the course of our last 5 webinars, that many of the cultures that are sent on patients and long-term care facility residents are positive but represent colonization, not infection. And it's important to keep in mind that those are all lumped together. Intermediate susceptibility results generally are considered resistant for the purpose of antibiograms, but again, those two things aren't the same, and it's important to keep in mind that some of what's considered resistant in your antibiogram may be only barely so. And you can't see multi-drug resistance using the type of antibiogram that I showed you. So you can see that a certain percentage of isolates are resistant to, say, penicillins, and a certain percent of isolates are resistant to the cephalosporins, but it will not tell you what percent is resistant to both of those things. And if you're using your antibiogram to show the success of your stewardship initiative, so if you are trying to show that the things that you have been doing to ensure prudent antibiotic use are actually changing your resistance rates, it's important to remember that there are other factors other than stewardship that affect resistance patterns. So the referral base, where your residents are being referred from. If you're getting more and more residents from more and more acute settings or from tertiary referral centers rather than community hospitals, for example, you may be seeing increasing resistance despite your best efforts to decrease antibiotic use within your facility. If you've improved your infection prevention activities, you may see decreasing resistance even if your stewardship initiatives aren't effective. You may see changes in resistance patterns or improvements just because of regression to the mean. Changes that spontaneously occur over time. And then we see some drastic shifts sometimes in susceptibility rates over the years because the definitions of resistance at the laboratory level have changed. So the breakpoints that are used to call an organism susceptible or resistant sometimes change, and that can have a dramatic effect on your antibiogram that is not actually clinically relevant. So one of the main things that you're going to use your antibiogram for is to look at resistance trends and to set your goals, to set your stewardship goals, to set your infection control goals. And the first thing you can do is simply look at the number of isolates cultured from every type, from every species. So here's an example of a time frame from 2013 through 2015 showing the gram-negative organisms. And you can see that several of them declined in frequency over time. And then if you break out one of those, Acinetobacter baumannii, you can look at susceptibility over time and to which antibiotics is the organism more resistant and to which antibiotics has the organism become less resistant, and correlate that with antibiotic usage at your hospital, and we'll show you how to do that. Or at your facility, sorry. You can also create graphs like this one showing ESBL rates over time, or carbapenem-resistant Enterobacteriaceae rates over time, and here you can see the rates for Klebsiella, Oxytoga, Klebsiella pneumoniae, and E. coli over the years 2012 through 2015, the percent of those that were extended spectrum natolactamase producers. We also use antibiograms to create clinical pathways and protocols. So this is an example that we published where we looked at only hospital-acquired urinary tract infection isolates in the year 2013. And we used these data in order to create our protocol for empiric treatment of hospital-acquired urinary tract infections. So if you look at this table here, it's easy then to find which is the single best agent for all of the organisms isolated from urine cultures in that year, and that was Tryptozoa and Tazobacter. little bit about how to trend changes in antibiotic susceptibility. And next I'm going to talk a little bit about how to measure and trend changes in your antibiotic use. So there are two different pieces to this measure, the numerator and the denominator. So first I'm going to talk about all of the different numbers that you can use to describe how much antibiotics you're using. The easiest one to select is just cost, looking at how much money are you spending month to month or over a given period of time on antibiotics. You can look at it, you can pull this as an aggregate cost from your pharmacy bills, and you can drill down to specific drugs or maybe combine them to look at drug classes. And ideally, this should be adjusted for your patient volume because spending $100 versus $1,000 versus $10,000 means very different things based on the number of residents you have in your facility. Another option for measuring antibiotic use that is relatively low in terms of not requiring a ton of labor, from your point, is to look at the proportion of patients who are receiving antibiotics. So this can be monitored either continuously throughout the month or just as a point prevalence, like on a single day or on a few random days that are used as a selective sample. Just look at how many patients are on antibiotics on that day. And again, this can be drilled down to go from as general as are they on antibiotics versus looking at specific drugs or drug classes. And this is provides a different useful dimension in describing antimicrobial use because it really describes, at kind of baseline, what is your usage like. This might be useful for identifying some of your potential unnecessary treatment in certain units or services if you notice that certain areas or certain types of patients are getting more antibiotics than others, and assess whether or not these people might be being treated for colonization or receiving inappropriate prophylaxis. And so the way you would do this is just look at the number of people that you currently have admitted to your facility and just count them up to see how many of them are actually receiving antibiotics at the moment. So here in this example, if there's 52 people living in your nursing home and 13 of them are receiving antibiotics, that means that your proportion of patients on antibiotics is 25%. Another measure that you can look at that's, again, relatively low input is the number of antibiotic starts. This can be measured continuously, and it's often viewed as a little bit more of a feasible way to track antibiotic usage. You can, if you don't have a lot of technology in place, this can be done as simply as logging in each antibiotic prescription when they enter, when the pharmacy delivers them. This is one of the best methods for tracking success with interventions that were designed to educate prescribers on situations in which antibiotics are not appropriate. So many residents may come into your facility already on antibiotics, and this measure is unique in that it's really training your prescribers on when to not use antibiotics, as opposed to just continuing what they were on when they came in. This method is not as good at measuring the success of efforts focusing around duration of therapy or early discontinuations due to an antibiotic timeout. But it is useful for measuring kind of when you're not using antibiotics. This should be adjusted by resident days. And this report can be created specifically for certain infections or for certain providers to kind of really drill down to the maximum impact that you're having. The next metric I'm going to talk about is a little bit more complicated, but provides a little bit more meaningful data. So the term defined daily dose, or DDD, was developed to estimate the average amount of drug that a patient is receiving each day. So it's relatively easy to calculate if you are able to pull or figure out how many total grams of antibiotic was used. And this is most available to hospitals that don't have sophisticated IT infrastructure, but should also be relatively feasible for you to obtain from your pharmacy drug list that you receive routinely to understand how much you're receiving of each drug. The DD assignment is based on a database that comes from the WHO, the World Health Organization, and it can be used for antibiotics, but just of note, this can be used, there's normalizing data for many, many drug categories that are non-antibiotics as well. So one of the pros of this method is that it's relatively easy once you have the reports available. It's very consistent over time, so this method really lends well to tracking change over time. You can, if you want to look at multiple things at the same time, you can easily add these numbers together. It does incorporate the impact of dose, and it can also easily facilitate a cost calculation. One of the things it does not do is incorporate changes in formulary or changes in practice patterns. So if one of your initiatives was to stop using antibiotic X and start using more of antibiotic Y, the two DDEs may not equal out perfectly, so you might not be able to necessarily tell if overall you're using less from this methodology. Also, this isn't the best for pediatric antibiotic use because their doses are so much smaller, and this sometimes can underestimate the contribution of patients that have kidney or liver failure because by nature of their disease, they may use less antibiotics, but that doesn't necessarily mean that they're not getting exposed to as much. They clear it out slower, so we give them lower doses, and it may seem, from a superficial reporting perspective that you're using less, but really it doesn't kind of play out that way. So I'm going to give you a couple of examples of how to actually use the DDD methodology. Here I have a patient who was receiving IV vancomycin, and for those of you that are familiar with this drug, you may realize that very often the doses need to be changed based on drug levels. So here I have a patient example that had to be changed onto 3 different doses over the course of a week. And you can go back and add up all of the different doses that they got in terms of number of grams to figure out what their total exposure was. Once you've figured out how many total grams a patient has been exposed to, you can go back to the DDD value from the WHO guidance and find that this patient received a total of 18 grams of vancomycin during their treatment course. The DDD normalizer from the WHO is 2 grams per DDD. So you just do a simple math of 18 divided by 2, and that gives you 9. So the patient RM, from this example, received 9 DDDs of vancomycin during this admission. And you can do the same methodology to compare lots of different patients for lots of different things. Now, it's thought of as a little bit more helpful when you start thinking about house-wide how many DDDs of drugs you're using overall. So here, in this example, your institution used a total of 374 grams of vancomycin. So that means going back and looking at your pharmacy reports to see how much grams total of drug you use. And then going back to that WHO normalizer, you can see how many DDDs you use, in any given month or quarter or whatever time period works best for you. This can get a little bit complicated when you start thinking about things like combination products. So Unison is a good example. That's ampicillin and sulbactam in one product. And the ratio within it is to be for every 3 grams of Unison has 2 grams of ampicillin. So it's 2/3 of the dose is ampicillin. And the 2 common doses of this drug are 3 grams and 1.5 grams. And respectively, you just have to figure out what percentage of that was the ampicillin component, because that's what the DDD is based on. So in this example, your institution bought 147 doses of the 3 grams a dose and 84 doses of the 1.5 gram dose. So when you add those together, that was a total of 567 grams of ampicillin sulbactam, or combination. But when you think about the fact that only 2/3 of that was ampicillin, then you get down to 378 grams of the ampicillin component. And that is the number that you would incorporate into the DDD calculation, normalizing by 6 grams per the WHO guidelines, giving you a total of 63 DDDs of unison for the month of March. Now, again, I acknowledge that this is a little bit complicated. Feel free to go back and relook at these slides, and if there's any confusion, feel free to reach out.
Yeah, why not?
Now, one of the benefits of using this method is that it's really, really clear at showing improvements or success in achieving your goals over time. So here's an example from our hospital that our goal was to reduce the utilization of daptomycin, both in the number of new starts as well as using more appropriate doses. And so we were able to see, although there were blips up and down, an overall trend towards decreasing our daptomycin usage over time. Now, the next method, days of therapy, is the most preferred method for measuring antibiotic use. This is the number of days in which a single antibiotic was given. Now, the caveat is that it requires patient-specific data to know which patients received antibiotics on which days. As I mentioned, this is considered the U.S. standard metric and the gold standard, and it can account for combination therapy. So if a patient was receiving 2 different antibiotics, each would count as 1 day of therapy, so a total of 2 days of therapy total. Some of the benefits or the pros of this is that it's not really affected by any changes if the WHO changes their reference. It doesn't really matter what dose the patient receives, and it can be accurately applied to pediatric patients or patients with end-organ dysfunction. But unfortunately, it doesn't necessarily incorporate some dosing variability that if you're having initiatives to try to reduce the magnitude of your doses. This may not always be the most clear indication of your total duration of therapy because it can be confounded by the fact that if a patient's getting more than 1 antibiotic at a time. As I mentioned, it does require patient-level data, which is a little bit more challenging to get sometimes, and sometimes can include partial days, which will just count as 1 day. So here I have an example for a single drug. If you wanted to know how many days of therapy of ampicillin did your institution use over a given week, and here I have different patients that received totally different doses of ampicillin. It doesn't matter what the dose was, just when did they start, when did they stop, so how many days were they on it. And you just add them all up to get the total numbers of days of therapy for that given week. When you incorporate a little bit more of the combination antibiotics, because many patients will receive more than 1 antibiotic at a time. Here we have an example of, a patient, Monica Green, who was on ampicillin, gentamicin, and clindamycin all at the same time for varying durations of therapy. Or, Rhonda Rouge, who was on piperacillin, tazobactam, and then switched to ampicillin. All of these kind of can make your days of therapy calculation a little bit more confusing. But it's a little bit easier if you just go line by line to figure out who was on which antibiotics for which days, and then just add them all up to get your total days of therapy. Now, the difference between defined daily dose and days of therapy really just has to do with how much variability is there in the dosing of that drug. So ceftazidime is an example in which the days of therapy versus the DDD are very different because patients can be on totally varying doses of ceftazidime. Ertapenem, however, is an antibiotic with a pretty standard dose. There's not really a lot of variability. Pretty much everybody receives 1 of 2 possible doses. And because of that, it's pretty standard in terms of the amount of variability between the DOD and DDD. The DOT and the DDD. They're going to tell you pretty much the same thing. The last measure I'm going to talk about is length of therapy. So this measures the duration of each antibiotic course each patient receives. And like the DOT metric, this does require some patient-specific data, but it does help to determine if you're treating perhaps longer than necessary. So many facilities have, different targets or different goals, and I know one of the easy goals to start with is trying to just reduce the durations of antibiotic therapy as opposed to trying to change what they are to begin with. Now, so the pros of this is that it provides aggregate level estimate of average duration among people who receive antibiotics, and just like DOT, it's dose independent, and can really be drilled down even to units or services or providers to provide really specific feedback on use. Unfortunately, this is not inherently normalized for length of stay, and it doesn't really work well for comparing different drugs, and doesn't really discriminate between treatment periods. So, as I mentioned, one person may get a course of antibiotics for 10 days, as opposed to a patient that may have 3 different antibiotic courses for 2 to 3 days, and that could include maybe if a patient was de-escalated, something that we've advocated for multiple times throughout this webinar series. If a patient had their antibiotics de-escalated, that technically can count as additional antibiotic days. This doesn't necessarily reflect combination therapy or the total dose, and can be a little bit cumbersome to calculate. So, again, here I have some patient-level examples, but just showing that when patients have a lot of antibiotic switches, you just have to count out, when did they start antibiotics, when did they stop antibiotics, and that's going to give you your total length of therapy. And then when you're looking at an overall population, it doesn't really matter, the days that a patient was on more than 1 antibiotic at a time. Their total length of therapy is from when did they first start antibiotics to when did they finally stop antibiotics. And next I'm going to talk a little bit about the denominators, because all of these metrics are good at telling you how much, but that taken out of context can be really misleading, because as I mentioned, there's some facilities that are participating in this that are, 20, 30 bed nursing homes, and there are some with over 100 beds. And when you think about how frequent turnover your residents may have, what acuity of care they require, all of these can really impact how you interpret the information that you're able to find. So it's really important that you normalize to something, and that's where your denominator comes in. So ideally, you would normalize to number of patient days, and this is an opportunity for you to account for any fluctuations that you may see in your census. It may be 100 patient days or 1,000 patient days, just so you don't have like tiny fractions that you're dealing with. But it does kind of help account for your overall census. And the way you would figure out your number of patient days is the number of patients that are under your care times their mean length of stay. An offshoot of that is days present, which is the CDC's preferred denominator. We talked a little bit in the last webinar about some of the reporting requirements that are on the horizon for the CDC through the NHSN database. And one of the things that they'll be looking for is this days present, which is essentially the number of days that a resident is within your care, including the day of transfer. You could also normalize by number of admissions or number of discharges, because those are essentially the same thing. So every patient gets admitted, they get discharged. And this is useful for institutions that are trying to reduce their length of stays or have relatively short length of stays, because they'll be a little bit more sensitive as their number of patient days decreases. But when we think about long-term care facilities that have really, really long length of stays, some have residents living there for years, months or years, this becomes a little bit less useful. And then with that, I wanted to open the lines not only for questions about this webinar, but we wanted to end early because we've gone over a couple of the earlier webinars to really address any questions that have come up over the last few sessions. Before we open up the line, I'm just going to send it back to Alizi.
Awesome. Thank you, Shira. So we can start taking the questions now. If you'd like to ask a question over the phone, please press #6 for the over-the-phone question, or you can pose your question on the chat box. And, so go ahead and ask any questions you have.
So one that came up the chat box is that most long-term care facilities do not have pharmacies in-house. How does slide 25 in regards to units apply to long-term care facilities? So, yes, we recommend that most long-term care facilities don't have pharmacies in-house, but you do have consultant pharmacists that would, provide you with the drugs, and many of them can be IV drugs like Unison or other combination products like Piprazole and Tazobactam, trimethoprim sulfamethoxazole or Bactrim, that would still need to be accounted for using the same fashion. And then also, these consultant pharmacies should be providing you some sort of metric so that way you know what you're getting. So whether it be a monthly bill or quarterly bill to recognize what you're paying for, so that way you can quantify how much of a certain drug that you're getting. In addition to that, I'd like to advocate for the role of the consultant pharmacist here, that they really can help, especially with the calculation of drug metrics. They really can help you out with figuring out how much of each drug you're using.
Perfect. Thank you. Again, that number is, if you want to ask a question over the phone, it's #6.
Lazy, this is Janet in Providence. I just had 2 comments. Can you hear me?
Yes. Yes, we can hear you.
I had one comment about the antibiogram and another about the pharmacy services. Number one, based on 25 years of experience working for a laboratory which provided services to nursing homes, I would urge all of the nursing homes who are on the line to make sure that if they are not receiving an antibiogram from their reference laboratory, to absolutely request it in writing. Make sure that the laboratory knows that you need it for meeting the updated reform of requirements for the antibiotic stewardship piece of it. An awful lot of work for the already overworked infection preventionist to try to put together his or her own antibiogram. That's my suggestion. They should really, even if they have to put a little pressure on their laboratory, that should be something the laboratory can provide. A lot of the machinery in the microbiology departments has a lot of data already available. And my second comment was about the pharmacy services. I know that, again, in speaking of meeting the updated reform of requirements, the Centers for Disease Control did meet with the primary pharmacy service providers to long-term care facilities. So, again, before a nurse in the nursing home is trying to do a lot of detailed calculations, they may want to make sure they ask their pharmacy, what are you planning to do to help us meet the updated reform of requirements? Press them a little bit and ask specifically what forms and in what way are you going to help us do that. just before they spend too much time. There may be nursing homes who do end up having to do some of these calculations on their own. And by the way, fantastic presentation on what some of those calculations might be. But just in terms of all of the work that is coming down on long-term care facilities, make sure that they have everything they can get before they start doing a lot of work on their own. Thank you.
Thank you. We have a couple questions on the frequency of antibiogram. An annual antibiogram is pretty standard. As I mentioned, the numbers may be small, and the data from a year might not be enough to get meaningful numbers. If you end up asking for, say, a 2-year antibiogram, you could still ask them to generate that annually and just have that be a rolling antibiogram covering the last 2 years, for example. So I would say that the expectations from your laboratory, if you're asking for that, should be annual. If you're making it yourself, I would recommend working on that once a year. Other questions in the chat box or by pressing #6 to unmute your line? So I guess with that, we'll close up. We don't really have a lot of other questions, but our contact information, all of your CDI and HSN state contact are listed on the slide here, as well as Shira and our contact information is also available through the website. We encourage you to follow the link, the healthcarefornewengland.org link that's in the chat box, and will also be emailed to you, so that way you have both the slide deck as well as access to the previous webinars that we've given, and we thank you all for your participation and questions.
Awesome. Thank you, Shira. Do you mind passing me the ball?
Sure.
Perfect. Okay, so if we don't have any more questions, I thank you all for the great discussions. I do have a few last announcements before we close today's call. As a reminder that we are now on social media, visit us on Facebook, LinkedIn, and YouTube. QIN-QIO welcomes your feedback. Please complete the evaluation once you close out the webinar. The evaluation will automatically pop up on your computer, and the PowerPoint presentation will be posted on the website within the next few business days, and a recording and transcript of this webinar will also be added. And if you're interested in accessing the rest of the series, you can visit the website. I did add the website on the chat box. It will also be sent out to everyone as on the thank you email, and you can access all the past recordings. And again, thank you for attending, and have a great day.